So, it is a true honor and privilege to welcome Professor Gabriel Oniscu, one of the most influential and visionary voices in European transplantation today. Professor Oniscu is an internationally renowned transplant surgeon, recognized for his leadership in innovation, organ preservation, and machine perfusion, donation after circulatory death, and strategies to expand access to transplantation. Currently, Professor of Transplant Surgery at Karolinska Institute in Stockholm, he has combined throughout his career clinical excellence, scientific leadership, and a remarkable ability to anticipate the future of our field. He also served as president of the European Society for Organ Transplantation, helping to shape transplantation policy, collaboration, and innovation across Europe. He is the ideal speaker for this inaugural lecture because he represents something essential for all of us, the belief that the future of transplantation will be shaped not only by technology and innovation, but also by humanity, equity, and truly patient-centered care, precisely one of the key topics of this Congress. Professor Oniscu, dear Gabi, thank you for being with us. It is a great privilege to welcome you to our Congress.
Buenas tardes a todos y a todas. Señor Presidente, distinguidos colegas y queridos amigos, es un verdadero honor impartir la conferencia inaugural de este Congreso de la Sociedad Española de Trasplantes. Es un privilegio estar ante una comunidad que no solo ha dado forma al trasplante moderno, sino que ha definido la que significa la excelencia, la solidaridad y la humanidad en el ámbito de trasplantes. I would continue in Spanish, but it'll take about an hour and a half instead of 30 minutes. So thank you very much. And really, Spain has long stood at a global benchmark in transplantation, not just in numbers, but in philosophy. A system built not only on organization and innovation, but on trust. Trust between professionals, patients, and society. And whilst we can spend the next 30 minutes or so recounting your successes, I invite you to look ahead and reflect. Not to the next breakthrough, not just to the next milestone, but really to a horizon where innovation and humanity must evolve together and shape the next decades of transplantation care. Innovation and humanity, two words that we often have difficulty reconciling, the science and the soul. But tonight I want to argue that by 2030 we have no choice but to unite them. Because by 2030, transplantation will not just simply be more advanced. It will be completely overhauled by technology. And in this context, our challenge is clear. Can we ensure that the future of transplantation remains deeply human, even as it becomes increasingly technological? But let's start with the beginning, because every transplant begins not with an operation, but with a human decision, and that is to give life, from death to life of others. But despite that extraordinary gift, every year more than 700,000 people still wait for a transplant globally. Only a handful of them will receive a transplant. The rest will wait, and many will die waiting. But behind each of those numbers, there's a person, a father, a child, a friend. I would want you to remember that more people die every day on the waiting list in Europe than civilians in the Ukraine war. An immense human potential purely wasted. The scale of the challenge we face is absolutely enormous. Across all organ types, demand vastly outstrips supply. Let's take lung, for example, 4 times greater need than supply. 50% of the grafts are lost within 10 years. 15 to 20% of people waiting for a liver transplant die waiting. This scarcity is not a temporary feature of transplantation medicine, but rather a structural condition that continues to define our field's landscape. The gap creates what has been described as an absolute scarcity of healthcare resources, where no amount of efficiency improvement or resource reallocation can eliminate the need for rationing decision. So in this context, the question is not how to ration, but why to ration, but how to ration ethically. And accepting that transplantation involves rationing transforms every clinical decision-making we take into an explicitly moral enterprise. And as such, transplantation cannot just simply be justified solely on medical or technical grounds, but must be defended according to the core humanity principles of justice, fairness, and social value. We are living in a golden era of transplantation with the most dynamic development we have ever seen in our field. And as such, it is difficult to forecast the precise future. But from today's viewpoint, where we stand today, the next decade of transplantation could be shaped by 4 converging forces. First of all, intelligent systems driven by artificial intelligence and machine learning that will shape everything we do. We are at the point of crossing biological frontiers through xenotransplantation and bioengineering. We will move towards precision medicine, which will be tailored immunosuppression and perhaps tolerance induction. But all of this will be around human-centered care, because transplantation is not just about graft survival, but more about more deeper human dimensions: equity, dignity, and quality of life. So let's start looking at those pillars. Artificial intelligence is already transforming transplantation, not in the future, but right now. This ESOT white paper, which was recently published, and I really encourage you to read, has shown that most professionals already see a change now and in the next 5 years. AI-powered algorithm will change matching and allocation, whilst prediction models will identify those patients who are at risk of losing their grafts before clinical signs appear. And this will be powered by wearable devices. The expectation is that of an increased diagnostic accuracy with increasing efficiency, leading to improved transplant success and better patient experience, again with a clear link to the human aspect of our activity. Tools such as MedSam, organ viability assessment, smart matching for organ optimization, and deep learning models for post-transplant complication detection and prediction are moving very quickly from research manuscript to clinical practice. So the question is no longer whether AI will change transplantation, it is how we will overcome the current concerns about the role of AI and how we will govern it to enhance transplant care. And as you can see here, that the focus in the same survey needs to be on transparency, improved regulatory environment, and data quality to inform those predictions. The growing progress in AI technology has actually raised an interesting question. Can AI make or assist decisions with a moral balance? Whilst there are a multitude of benefits of using AI in such domains, including efficiency at scale and the attenuation of human cognitive limitations, we have to acknowledge that human moral decision-making processes are highly complex. And it should not come as a surprise that AI at the moment cannot capture all the nuances involved, especially how people process morally relevant factors, develop informed preferences over moral attributes and values, and put those together to make a final judgment. But then obviously we have the next step, which is really crossing the species barrier. And as recent as 10 years ago, xenotransplantation seems like science fiction. It was always around the corner. Today we are looking at one of the most disruptive innovations in human history entering clinical arena. And approvals have already been granted for first-in-human clinical trial. The pace of progress has been nothing short of extraordinary. In 4 or 5 years, we have moved from a decedent model to the first kidney transplant in a human, followed by heart transplantation, and in the last 2 years, survival that begin to be measured in months rather than days. And the trajectory to 2030 is extraordinary. Will continue because of conditional regulatory approvals and hopefully integration with machine perfusion for ex vivo assessment. It's ambitious, but it's achievable, and hopefully this will also allow us to move xenotransplantation in Europe to catch up with the US and China. Because if xenotransplantation succeeds, it does not just solve the organ shortage, it eliminates it. In parallel, organ bioengineering is advancing along 2 complementary tracks. Decellularization, stripping donor organs, be it human or porcine, of their scaffold and reseeding with recipient's own cells, offers the possibility of immunologically tolerant organs. 3-dimensional bioprinting is moving from simple tissue constructs to vascularized components. We are not yet there to print whole organs, but we are printing kidney tubules, liver organoids, and vascular networks. Again, the 2030 horizon for bioprinting is not whole organs, but it's functional tissue patches and organoids for drug testing and bridging therapies to transplantation. Undoubtedly, machine perfusion is perhaps the most immediate, impactful innovation in transplantation today, and this audience needs no reminding of where we are. Many strategies have been promoting from cold to warm and anything in between. And there's no doubt, however, that normothermic technology is the one that will make the most significant difference long term, because it allows us to assess viability, treat injury, and extend preservation time, and as a result, allow us to use more marginal organs that perhaps in the past would have been thrown in the bin. But this does not come without challenges, and we need to address those in the next 5 years. And those include the impact on the current clinical practice, the regulatory environment that is about to change yet again in Europe, the costs, and the suitable infrastructure. If we do not fix this, there is a significant risk that these technologies will fail and will further exacerbate rather than address unequal access to transplantation across the European continent. But really where machine perfusion technology, in particular normothermic one, will make a difference is in the context of organ repair. Transplantation will shift from the traditional pathway of donor, organ, recipient to a personalized approach where organ repair will be undertaken on a machine. Several strategies are currently explored focusing on addressing the ischemic perfusion injury that an organ sustained during the dying process and transplantation with some key running actors, senolytics, gene modulation, and nanoparticles as vectors to deliver such therapies. But this is only the beginning. It is the first step towards bioengineering. Really, this is where technology will meet biology and truly transform the field, leading to the expansion of transplantation possibilities. And whilst we are beginning to discover the route to repair, harnessing our own body's regenerative potential, we still have some way to go before clinical application. All this innovation and technological development will rewrite transplantation pathway, but these developments are expensive, require financing, infrastructure, knowledge, and can only be achieved in multidisciplinary clusters that bring together not only scientists and clinicians, but technology, industry, to spearhead rapid development and translation from bench to practice, enable all these technologies to evolve cohesively. It is an approach that we have adopted in Karolinska, where we set up this clinical and translational research hub, where we bring together disruptive innovations, including machine perfusion technology, imaging, virtual AI, and cell therapy, to facilitate not only technological development, organ repair, but also drug and ATMP testing and development, but also, and critically important, enabling human development through novel skills and jobs. While most of those innovations that we talked about will address the organ shortage, we need to remember that the patients will live most of their lives with a functioning transplant, hopefully. And whilst we have enhanced survival, still 50% of the grafts are still lost within 10 years. For 50 years, immunosuppression transplantation has just been a blunt instrument. We have given the exact same drugs to every patient and adjusted based on toxicity and the risk of rejection. Precision medicine is about to change that, because pharmacogenomic profiling, biomarker-guided protocols, and novel approaches, which may also induce operational tolerance, are likely to change this. The motto of your Congress mirrors what I'm about to say, because by 2030, the vision should really be one organ for life, where every patient has a graft that lasts their lifetime. But in order to get there, we need just more than just simply personalized therapeutics. This will not be sufficient. We need to transform the post-transplant journey. Wearable devices that monitor vital signs, activity, and early signs of rejection are essentials. They will form the basis of remote follow-up and monitoring that are supported by easily accessible platforms. And these have the potential to democratize access to expert transplant care, bringing specialist-level surveillance to patients in all underserved communities and low-resource settings. But really what we need to make a cognitive and also a conceptual shift here, a shift from our current way of practicing medicine in office base to a continuum of care where the patient is firmly in control and in charge of their care, supported by all the technologies that are available to provide constant and continuous monitoring to their transplant. So then we can detect early signs and intervene to maintain graft function before irreversible damage has occurred. But herein lies the paradox, really. Will digital health be a bridge or a barrier? The same technology that can eliminate barriers, geographic barriers, can actually create new ones. Remote monitoring, of course, can reach rural patients if they have a smartphone, if they have connectivity, if they have digital literacy, and if the interface is in their own language. AI can also reduce implicit bias in clinical decision-making if it's trained on diverse data, if it's audited for subgroup performance, if it's governed by equity-aware frameworks. Technology is not inherently equitable. It reflects the values and the prejudices of those who have developed it, and therefore we might choose equity as a design requirement for this. And this brings us nicely to the fourth pillar, the essential link between technology and humanity. Because as we celebrate these extraordinary developments and advances, we must confront a very uncomfortable truth. The benefits of transplantation have never been equally distributed. And in this brave new world that we are entering, technology and innovation really risks to further these inequalities to the point that it becomes a privilege rather than a progress. To change all this requires a joint effort at multiple levels and interventions at patient level to improve their health literacy, at clinician levels to reduce our biases and interpretation of risk, at center level to increase lean practices, and of course at system level to firmly put transplantation on the policies and on the political agendas. Otherwise, there will be no trust in the system, and we will have no solid ground to introduce innovation and technology, and we will fail to achieve the desired effect of improving outcomes and access. I would like you to take a moment to consider what is the most important question to address to 2030 in order to shape transplant care. Is it really building a better algorithm? Is it bringing a better machine perfusion? Or is it building introducing groundbreaking innovation? No, it's not about that. It's about building a better system, one that works for everyone. Because where humanity, technology, and equity meet, this is where the future of transplantation will be decided. And as such, equity cannot be retrofitted. Efforts to mitigate algorithmic bias, for example, require more representative data sets to allow us to assess it. But that alone cannot fully eliminate the risk of unintended consequences. So we have created sophisticated tools such as fairness metrics and bias detection tools to identify and correct disparities in development and deployment phase. And while all these metrics actually provide quantitative measures of whether an algorithm treats groups equitably, they may conflict with each other, in fact, because they require explicit choices about which conception or which concept of fairness to prioritize. Therefore, the human element is essential. There's a need for stakeholder engagement, starting from AI developers, clinician, patient advocacy group, to promote transparency and explainability. Our growing reliance on algorithm and AI introduce new challenges related to transparency and accountability, and may end up functioning as what is called an algorithmic shield that deflects moral responsibility away from human decision-making factors. Let me explain this a little bit more. When an allocation algorithm, for example, can be attributed to, when an allocation decision can be attributed to an algorithm, individual users may feel absolved of any moral responsibility for the outcome and possibly say, well, it was the algorithm that decided. And that is good for our psyche because it allows us to maintain a self-positive image irrespective of the outcome. In other words, whether the patient dies or not on the list. The algorithm can easily become a scapegoat, a convenient one, as we can claim that all it did was merely implementing a technical system rather than making moral choices. This deflection is ethically problematic for several reasons. First of all, algorithms are not morally neutral technical elements, but rather embody specific ethical values and priorities determined by their designers. The choice of which factor come into an algorithm, how to weigh different criteria, and which trade-offs to accept are fundamentally moral decisions that cannot be reduced to technical optimization. Secondly, algorithms do not eliminate human judgment, but it rather allocates it further up in the design phase where it may be less visible and less subject to scrutiny. This makes it very unclear who is responsible. Is it the developers? Is it the users of the algorithm or the algorithm itself? And if you think about it, this is likely to become even more challenging as deep learning expands the unsupervised developmental algorithms. Just put it simply, when algorithms are not developed by humans, but they are developed by the machines, who will bear ultimate responsibility? Thirdly, algorithms require human input and interpretation, and also implementation, creating opportunities for selective adherence or discretionary judgment in how we interpret this. And this may not be necessarily adequately acknowledged or justified. And as algorithms become more complex and incorporate more variables, they risk becoming black boxes, decision-making systems that produce output that cannot be easily explained and understood by the clinician and the committees who implement them, let alone by the patient and the public. Through their complexity, blood boxes algorithms obscure the human values and the trade-offs embedded in human rules. When these choices are hidden with opaque formulas, they escape public scrutiny and cannot be explained to patients and therefore transparency, accountability are essential. Keeping humans in the loop is a critical step, but it's meaningful only if humans in the loop understand and engage with the algorithm output rather than just simply rubber stamp them. Everything we discussed so far is putting us at the frontier of innovation, and this is not new for our field. We have always lived at the frontier of innovation throughout the last 60 years of transplant. But these innovations are now raising profound and fundamental ethical questions beyond anything we faced before. Consider for a second some of the questions. Xenotransplantation, do we really have the right to engineer animals for human use? What about AI allocation? Who is responsible when the algorithm makes a life or death decision? Go back to the machine perfusion. How do we define the moment when an organ is defined as fit for purpose, viable? And how and what are the implications for consent for the recipient? These are not questions for the philosopher alone. They are questions for everyone in this room and beyond. We must engage with them, or otherwise others will find the answers for us. But it's not just about the ethics. These innovations will have a profound impact on the moral responsibility of decision-making. Fueled by the increasing reliance on algorithm and AI and multidisciplinary teams that make decisions, we can be in a situation when potentially no one decides. And this accountability gap undermines trust, reduces incentives for careful moral judgment, and makes it difficult to detect and correct problems. When no one decides, harm does not disappear. It merely becomes more difficult to find and name. And therefore, it's perhaps time to redefine the moral responsibility in this brave world we are entering, where technology, AI, and algorithm are commonplace. These reforms are essential not for the ethical integrity, but also for the long-term sustainability of transplantation as a social enterprise. And therefore, it can be argued that the best way to sense check this and to make sure we see the reality is to actually listen to the patient and include their voice in views in the future of transplant care. Because at the center of everything we do is the patient, not the organ, definitely not the algorithm, the person. And there is mounting evidence that is clear. Transplant outcomes are better if patients are active partners in their decision-making and the care, when they understand the treatment, when their quality of life is systematically measured and acted upon, when they have access to a support network, psychologists, patient navigators, and peer mentors. You may well have the most advanced transplant program in the world, but it will fail if the patient cannot navigate it, afford it, or trust it. Beyond this technical design, we really need a fundamental shift in how we develop transplant systems. The communities most affected by the transplant inequities must be the ones who co-design it, not just simply be recipients of it. Culturally concordant education delivered in native languages, patient-reported outcomes measured, truly multidisciplinary team involving a wide range of support are not just needed, are essential for ensuring the human aspect of an increasingly technological world. And when we build new machines, new innovation, new AI, patients and community must be involved in defining what is a good outcome. What does it mean before we actually train those algorithms to optimize them? But this technology and community engagement alone are not sufficient, really. We need structural policy change. We need transparent algorithm governance because they must be subjected to audit, public reporting, regular review. Equally, digital health will make a huge impact, but it must be assessed before we roll it out. So we need governance and at the highest level. So let's bring this together. How will transplant ecosystem look in 2030? I'm going to paraphrase André Malraux, because transplant will be patient-centric and technological, or will not be at all. It's not about disparate technology. It's about integrated technology with one aim, to preserve the humanity of what we are really trying to achieve. What are we trying to achieve? 0 preventable death on the waiting list. No organs should be discarded anymore, and we should ensure equitable access to a successful and lifelong lasting and fulfilling transplant. Tall order? Maybe. But it is our collective responsibility to achieve this. By 2030, we may well have smarter machines, better organs, the most recent technology, more powerful therapies. But really, the true measure of our success will not be technological. It will be human. Because ultimately, the future of transplantation is not written in innovation or algorithm alone. It is written in the compassion and the humanity of every person in the field. Thank you.
Thank you, Professor Onitsku. Excellent. Thanks for being with us, and thank you for this amazing lecture that you presented to us. Thanks.
Thank you.